So most of you all already know me, but my name is Kathleen White. I'm one of the PGY1 pharmacy residents here at Erlanger, and I am super excited to present on management of acute atrial fibrillation to you all today. And we'll talk about this a little bit more in a minute, but we're going to be focusing on mainly heart rate control, and then some other updates in the literature surrounding other concepts in acute atrial fibrillation management. I have no conflicts of interest to disclose. Our objectives for this presentation are to review atrial fibrillation prevalence, pathophysiology, and acute presentation. We're also going to explain different treatment options for management of acute atrial fibrillation based on patient presentation and comorbidities, describe the relationship between atrial fibrillation and acute disease states, and then associate acute atrial fibrillation management principles to patient cases. And then just prior to jumping in, I wanted to have a slide that just kind of addressed some of the abbreviations that you'll see throughout the presentation. So AF or AFib, atrial fibrillation. So these are abbreviations that you're very familiar with at this point, but NSR, normal sinus rhythm, EKG, electrocardiogram, and then these guideline abbreviations, so AHA for the American Heart Association, ACC for the American College of Cardiology, the Heart Rhythm Society, and then the European Society of Cardiology. So just for brevity, these society title, like names and titles are abbreviated throughout the rest of the presentation. So jumping into our background, just a general definition idea of what atrial fibrillation is. So it is supraventricular tachyarrhythmia with uncoordinated atrial electrical activation, resulting in ineffective atrial contraction. You'll also see irregular RR intervals on an EKG, and you'll also note complete absence of P waves, and this will kind of direct you to presume that these patients are in active atrial fibrillation. So when you have these uncoordinated electrical signals in the atria, it basically prevents your atria from contracting effectively. So it does diminish blood flow from the atria to the ventricle. And it can also cause other complications as far as signaling from the atria to the ventricle. So jumping into prevalence, internationally, this is a very common sustained cardiac arrhythmia, so affecting 2.4% of adults. It is also the most common arrhythmia present in patients presenting to an emergency department. And then in the United States in particular, it affects 1.2 million new people annually, and this is projected to increase by 2030. Risk factors for atrial fibrillation include heart failure, which we'll talk more about later on, vascular disease, valvular disease, CAD, hypertension, diabetes, CKD, inflammatory diseases, COPD, obstructive sleep apnea, obesity, smoking, alcohol use, hyperlipidemia, physical inactivity, and then acute illness and surgery. So as I previously mentioned, atrial fibrillation is characterized by high frequency excitation of the atria, resulting in unorganized atrial contraction and irregular ventricular excitation in this contraction. So we essentially view this mechanism of atrial fibrillation in kind of two different components. So you have the atrial fibrillation substrate, and I view this as kind of the resting environment that promotes potential decompensation into atrial fibrillation. And then you have a trigger. So a lot of these kind of more chronic conditions that we also listed as risk factors for atrial fibrillation can promote this AFib substrate environment. So in particular, fibrosis will slow conduction from the atria to the ventricle and also affects your electrical uncoupling. A lot of these chronic conditions also promote inflammation, which can further exacerbate and promote this AFib substrate as well as contribute to fibrosis. There are also cellular and molecular changes, so reduced this intracellular cardiac or calcium overload can also cause prolonged refractory period for the ventricles. So all of these kind of coalescing variables can contribute to this AFib substrate. And then you ultimately will have a trigger that causes somebody to go into atrial fibrillation. And this is very commonly acute illness or even surgery. You'll also see that once a patient goes into atrial fibrillation, they'll undergo additional electrical and structural remodeling, which further promotes atrial fibrillation, and then also can develop or can contribute to further development of those risk factors, comorbid conditions that promote the atrial fibrillate substrate. And this development of AFib and this AFib substrate really kind of connect us to our cardiovascular outcomes that we're concerned about with atrial fibrillation. And I have some of these listed here, but we're also going to talk about them on the next slide. So our outcomes that we're concerned about, there's increased mortality associated with atrial fibrillation. There's also increased risk of stroke. Atrial fibrillation is connected or highly associated with left ventricular dysfunction or heart failure. And these patients, AFib patients will have like a frequency of 20 to 30% will also develop heart failure. You can also see cognitive decline and vascular dementia with AFib, can promote development of depression, impaired quality of life, and hospitalization. So they have a pretty high hospitalization rate, 10 to 40%. In looking at the progression of AFib, really most patients present initially with paroxysmal AFib. So really kind of these short bouts of AFib that can terminate spontaneously within 24 to 48 hours, or we can terminate those pharmacologically or using electric cardioversion, or they terminate within 7 days. So kind of a shorter period. And then as this disease progresses, as you continue to see development of that atrial fibrillation substrate and increased frequency in episodes of atrial fibrillation, that duration is prolonged and you see more profound electrical changes, and that promotes this transition from paroxysmal AFib to persistent AFib. So AFib that is lasting longer than 7 days, or even longer lasting AFib greater than 12 months. At this point, when you have this continual building of that AFib substrate and also development of other comorbid conditions, eventually you will have such profound electrical changes and then structural changes that put some patients into permanent atrial fibrillation. So they are consistently in that rhythm. We cannot restore sinus rhythm, or clinically we make the decision to no longer pursue restoration of sinus rhythm. There was a survey, the European Heart Survey, which followed 5,333 patients with AFib for 1 year. And they found that 80% of patients that had paroxysmal AFib remained paroxysmal, whereas 30% of patients with persistent AFib progressed into permanent. So most of our patients are going to be presenting with this paroxysmal AFib history, which is kind of why our acute management of their atrial fibrillation and management of their heart rate is more important. Or is also important. So we typically approach atrial fibrillation treatment in kind of two kind of wheelhouses or ideology. So you have rate control versus rhythm control, which we'll talk about on the next slide. So our goal in rate control is slowing electrical conduction to the AB node, to the ventricles. We have 3 groups that we're typically using. Our class 2 antiarrhythmics are beta blockers. Class 4 antiarrhythmics are non-dihydropyridine calcium channel blockers. Here we're going to mainly be talking about diltiazem, then for our beta blockers, mainly metoprolol. And then you also have kind of an additional option in your cardiac glycoside with digoxin. So more on these to come in the coming slides. I'm not going to spend a ton of time on rhythm control. The focus of this presentation is management of acute atrial fibrillation, so heart rate management. But for your goal for rhythm control, symptomatic and functional improvement, we have 3 classes that we're going to be looking at for these. So class 1A antiarrhythmics, procainamide, class 1C antiarrhythmics with propafenone and flecainide, and then class 3 antiarrhythmics. We will talk about amiodarone in this presentation, but in general, we're going to be not spending a ton of time on these rhythm control agents. And kind of tying back in what our overarching goals are in atrial fibrillation management, and these are important in the chronic management of atrial fibrillation, but also in the acute management. So ultimately preventing stroke, systemic embolism, cardiovascular, and all-cause mortality. We're going to be concerned about symptom management, quality of life improvement, preventing hospitalization. So particularly in our acute heart rate management, and a lot of these trials are in the ED, or studies are in the ED. So preventing further admission and hospitalization is one of our goals in acute management. And then minimizing medication side effects and prevention of long-term physiologic changes. So preventing that kind of further development into persistent and permanent AFib. Okay, so the focus of this presentation is really on that acute heart rate management, focusing in on rapid ventricular response. So in the acute setting, you have this accumulation of this arrhythmogenic substrate, this AFib environment. And you also have irregular electrical signals from the atria. So this kind of development into atrial fibrillation rapid ventricular response can be precipitated by some kind of singular event or stressor. And so this irregular activation of the atria leads to irregular ventricular activation. And you'll see a reduced ventricular refractory period as well. So you'll have increased and erratic signaling to the ventricles, reducing or causing the heart to pump faster, if less effectively. So this faster paced irregular contraction has negative downstream ramifications, including increases in risk for further decompensating into ventricular tachyarrhythmias, which has a threefold increased risk of devolvement into ventricular fibrillation. You'll also see rapid ventricular response and result of these irregular atrial signals, which results in impaired ventricular filling. So you already have impaired filling in this irregular contraction of the atria. So provision of blood from the atria to the ventricle, so you have reduced ventricular filling, but then also as the ventricle starts to beat faster, it's not filling as appropriately or as fully as it could. So ultimately this results in reduced cardiac output, which also kind of contributes to this potentially damaging cycle of we have reduced cardiac output, so the body tries to compensate for that, further increasing our ventricular rate. And then also you can have decreased coronary perfusion, leading to ischemia, increasing myocardial oxygen demand, and then initiating or worsening heart failure. So pretty, we want to manage these patients very quickly in the acute setting to prevent this kind of decompensation into this hemodynamically unstable environment, and maintain our cardiac output and perfusion to vital organs. Okay, so where do we start? So initially when this patient presents, you're going to assess the rhythm. You're going to do this using a 12-lead EKG, and you're going to really be determining, do they have atrial fibrillation or do they have normal sinus rhythm with tachycardia? If they have normal sinus rhythm with tachycardia, then you're going to be managing the other underlying causes potentially for that tachycardia. So electrolyte management, managing other underlying medical conditions, or even potentially assessing if there are medications that could be contributing to this tachycardia. If they have atrial fibrillation, then your first step is going to be assessing if they are hemodynamically unstable. So there are two kind of heart rate, I guess, guidelines that are set forth by ACLS and the European Society of Cardiology for determining if a patient is at risk for hemodynamic instability. So ACLS says greater than 150 beats per minute, you're going to be concerned about hemodynamic instability, but the European Society of Cardiology sets that a little bit lower at 120. So overall, our heart rate target is determined by the RACE-2 trial, which mainly looked at kind of the chronic management of atrial fibrillation and setting that heart rate target. So they followed 614 permanent patients with AFib for up to 3 years, and they found that there was improved or reduced poor AFib-related outcomes at 3 years with lenient heart control less than 110 beats per minute, as opposed to more strict heart rate control less than 80. So we apply these heart rate goals in the acute setting as well, and you'll see these goals in our studies and trials that we'll discuss today. The guidelines also break down your further heart rate management into 4 kind of more distinct groups. So our hemodynamically stable groups, and the guidelines say that metoprolol, tartrate, diltiazem, verapamil, digoxin, and amiodarone are options for these patients. With patients that have HFrEF but are hemodynamically stable, the guidelines say metoprolol, tartrate, followed by digoxin and amiodarone. For critically ill patients, they recommend amiodarone as a potential option. And then for hemodynamically unstable patients, they recommend electric cardioversion. So we're going to start by briefly overviewing some of these more common drugs that we're going to see. So our beta blockers, main mechanism of action here is antagonism of the beta-1 receptor. So this decreases conduction through the AV node and also has reduced effects of catecholamines on the myocardium. So similar rate control compared to some of to our non-dihydropyridine calcium channel blockers via this negative inotropy and vasodilatory effects, but they also have some neurohormonal modulation that makes them separate from our non-dihydropyridine calcium channel blockers. So metoprolol tartrate is going to be our main agent that we're going to use from this class, although there are potential indications for esmolol. But for metoprolol tartrate, we're doing IV dosing in the acute management of heart rate. So looking at 2.5 to 5 milligrams IV boluses up to 5. Pretty rapid onset as far as these agents go. So most of these trials actually infuse metoprolol over 20 minutes or over 10 minutes. So kind of that onset of action within 10 minutes, although onset is a bit more rapid with IV bolus administration. Contraindications would be acute heart failure and history of severe bronchospasm and asthma. Side effects, precautions, they may potentiate hypoglycemia, they can cause bradycardia, bronchospasm, and they also have some reversible CNS effects and rebound tachycardia. For our non-dihydropyridine calcium channel blockers, they mainly work to decrease depolarization through the AV node by inhibiting voltage-gated slow calcium channels. They also cause relaxation of coronary vascular smooth muscle and coronary vasodilation, which ultimately slow heart rate. And these are kind of overarchingly categorized as negative inotropic effects and vasodilatory effects. In our studies, we mainly use diltiazem. We're going to basically only be talking about diltiazem from this class for the rest of the presentation. IV dosing for that typically is the 0.25 mg per kg IV bolus over 5 minutes. And then there is an option for starting a continuous infusion of 5 to 15 mg per hour. Onset is rapid at 3 minutes. Contraindications for this group is typically contraindicated in HFrEF. And then you also want to be adapting your doses in hepatic and renal impairment. Also notably, these can cause first and second degree AV block and also complete AV block, sinus bradycardia, and they're also known for their CYP interactions. So they do cause moderate to weak CYP3A4 interactions that may be potentially important in considering the use of these drugs. Some of our oral anticoagulants can be affected by these interactions. So just an important point to keep in mind in the use of the potential limiting use of these drugs. So not going to spend a ton of time on digoxin, but it is our cardiac glycoside, mainly inhibits sodium potassium ATPase pumps in the myocardial cells, resulting in transient increase in intracellular sodium, promoting calcium influx, and thus reducing this heart rate. So they have a narrow therapeutic index. Therapeutic range is typically considered between 0.8 to 1.2, and you want to be careful about dosing and renal dysfunction in the elderly. Also of note, there was increased mortality noted among patients that had heart failure that were treated with digoxin. So IV administration, so 8 to 12 mics per kilogram over 24 hours. And you would split this loading dose up for heart rate control. Onset can be between 5 to 16 minutes, we typically consider it as a drug that can potentially take a little bit longer compared to our previous two options. And then you can't use it in patients that have Wolff-Parkinson-White syndrome, that have acute myocardial infarction. And we also have seen that it's not as effective in patients that have a high catecholaminergic state. And then touching on amiodarone, a mechanism of action inhibits adrenergic stimulation, and then it also affects sodium, potassium, calcium channels. So ultimately prolonging action potential and refractory period in the myocardial tissue and decreasing AV nodal conduction. With this agent, what's kind of limiting for it in the acute setting is that you can cause unintended cardioversion. And so in some specific patient populations, you want to specifically avoid cardioversion for the risk of thromboembolism. IV administration dosing is typically 150 milligrams IV over 10 minutes, followed by 1 mg per minute over 6 hours, and then further decreased to 0.5 mg per minute over 18 hours. Onset typically is more prolonged. It can cause phlebitis, hypotension, bradycardia, QT prolongation, and then also has a pretty notable side effect profile, which also can limit its potential use. And then finally, just kind of rounding out our general treatment approaches for these patient populations. For your hemodynamically unstable patients, the guidelines recommend direct current cardioversion. So this is typically using about 200 joules, and really you're just trying to restart the cardiac cycle to let the sinus node bleed. We're not going to spend a ton of time talking about direct current cardioversion and focus more on some of our drug agents. Okay, so for our first patient case, we have patient RG, who's a 59-year-old male presenting with dizziness, shortness of breath, and feeling like my heart is about to race out of my chest. He was diagnosed with paroxysmal AFib in 2019. He also has a history of STEMI, SASPOS PCI in 2018, hypertension, hyperlipidemia, and he also is a smoker. So in just looking at his presentation, we already know that he has a history of paroxysmal AFib. His blood pressure is actually doing okay at 129/73. Heart rate is elevated at 149 beats per minute. And our EKG indicates that we have atrial fibrillation. So first question, is patient RG currently hemodynamically stable? Yes. And then what is going to be our optimal agent of choice for this patient? And we're going to talk about that a little bit more in this next section. So specifically looking at management of atrial fibrillation with rapid ventricular response in hemodynamically stable patients. So the AHA, ACC, HRS guidelines state that you can use IV administration of beta blockers or non-dihydropyridine calcium channel blockers to slow the ventricular rate in patients that do not have pre-excitation syndromes. The European Society of Cardiology guidelines echoes this. And they say that basically these agents are preferred over digoxin because of their more rapid onset and effectiveness at high sympathetic tone. So neither guideline specifically differentiates between one agent over the other in efficacy in this population. And they also recommend choosing an agent based on more patient-specific factors and safety. So really some of the goals for the literature that we're going to look at in answering this question are, is there a difference in efficacy between these drugs? And are there other considerations or side effects that might make us pick one over the other? So our first study was published in 2015 by Fromm and colleagues, and they were specifically looking at IV diltiazem versus metoprolol for AFib RVR in the ED. So this was a prospective double-blind randomized trial. They looked at 54 patients presenting to the ED with AFib definitively on an EKG with a rate of greater than 120 beats per minute and a systolic blood pressure greater than 90. Their primary outcome was rate control, defined as heart rate less than 100 beats per minute. So that is a little bit different from our typical heart rate goal within 30 minutes of IV drug administration. As far as their baseline characteristics, pretty similar in their blood pressure or mean blood pressure, and then also a slightly higher mean baseline heart rate in metoprolol, but not significantly different. Also notable, most of these patients had new onset AFib at presentation. So they were specifically looking at diltiazem dose 0.25 mg per kg with a maximum of 30 milligrams versus metoprolol dose at 0.15 mg per kg with a maximum of 10 milligrams over 30 minutes. Down here on the bottom left, there's a really neat chart looking at the heart rate changes that they saw with both of these groups over time over this 30-minute interval. So they found that 95.8% of the diltiazem group reached their goal heart rate within 30 minutes compared to 54.6% of the metoprolol group, and this was a significant difference. They also saw greater incidences of hypotension in the metoprolol group compared to the diltiazem group, but no difference in bradycardia between groups. None of these patients required cardioversion or converted spontaneously to normal sinus rhythm. So really in this article, they were directly assessing heart rate efficacy between these two agents, and diltiazem in this case came out on top with greater heart rate reduction in a relatively quick amount of time. Our other trial is conducted by Demirkin and colleagues. This was done in 2005, again, comparing effectiveness of IV diltiazem and metoprolol and rapid ventricular rate. This was a prospective double-blind randomized trial. They looked at 40 adult patients presenting with confirmed atrial fibrillation, heart rate greater than 120 beats per minute, and systolic blood pressure greater than 95. Their primary outcome was looking at heart rate control, specifically targeting less than 100 beats per minute, or a decrease in ventricular rate of 20%. And they were looking at 20 minutes post-infusion, so a much shorter interval for assessing their heart rate control. And these patients, they also had not terribly dissimilar mean baseline blood pressure, with metoprolol having slightly higher blood pressure, but their heart rate was roughly the same and not significantly different. So again, the maximum dose allowed for diltiazem in this study was 25, maximum for metoprolol was 10. In the bottom left, you see their plotted heart rate control over time comparing diltiazem and metoprolol. And really what they found was that there was not a significant difference between groups in this study. So 90% of diltiazem patients achieved the primary outcome of heart rate control compared to 80% of the metoprolol patients. Also saw slightly higher reports of hypotension with the metoprolol group compared to the diltiazem group. So these are the two main trials looking at the use of these agents for acute heart rate management. And kind of the big points that I want to stress here is that these were relatively small trials. They also had pretty extensive exclusion criteria, which kind of reduces their generalizability. So some of the notable exclusion criteria included any patients with COPD. They excluded any patients that had diabetes, peripheral vascular disease. So a lot of our comorbid conditions that we're going to see in a lot of our patients here in the United States. Also, this was really kind of a snapshot in acute management of atrial fibrillation. So only looking at their heart rate control at a very short time interval. So as far as kind of our other outcomes that were concerned with AFib, these trials did not necessarily assess those. It was purely just heart rate change over a short amount of time. The next study was a retrospective cohort study of adult patients presenting to an ED between January 2015 and June 2019. And this was published in 2021. They were looking at metoprolol versus diltiazem for rate control of atrial fibrillation. However, they did not require an EKG specifically determining that the patient was in atrial fibrillation. So they included 349 patients that received at least one dose of IV diltiazem or metoprolol, had a ventricular rate greater than 120 beats per minute and a systolic blood pressure greater than 90. Their heart rate, or their primary outcome, was heart rate control less than 110 at 2 hours post the last IV bolus. And then as far as baseline blood pressure and heart rate, roughly pretty similar between groups. So this was a retrospective study. And so they found that as far as dosing comparisons between diltiazem and metoprolol, diltiazem was dosed more consistently compared to what we saw in the other trial data, but metoprolol was roughly similar, but in some cases potentially lower. And talk about that more in a second. So what they found here was that there was a significant difference in heart rate change between metoprolol and diltiazem at half an hour, which echoes what we saw in our study from Fromm and colleagues. But this difference was lost at 1 hour and 2 hours post administration of the IV medication, kind of signaling that at least at 1 hour and 2 hours post infusion or post-administration, there really was no difference between groups. They also saw that rate control was higher in patients on diltiazem continuous infusions. So potentially some of the efficacy of diltiazem in this study could have been more towards or more related to the continuous infusion and not necessarily to the IV bolus dosing that's recommended. They also looked specifically at patients that had an admission diagnosis for atrial fibrillation. So in this population, they saw a greater difference comparing metoprolol versus diltiazem in heart rate reduction in patients achieving this goal at 1 and 2 hours. Not statistically significantly different here, but it is a difference. They also saw faster heart rate control, which is further highlighted here. They looked at patients that also had documented fluid overload, so kind of trying to tease out some of those patients that could have potentially some kind of presentation of heart failure exacerbation. And they found greater heart rate control with diltiazem compared to metoprolol at 1 hour. But then this benefit was kind of lost at 2 hours. And they also saw in these patients, there was no significant differences in rate control in any documented heart failure, HFrEF, or HFpEF. So kind of your takeaways from this presentation or from this study, they had less strict inclusion criteria compared to our trial data. So they included not just AFib patients, any patients that received an IV dose of these medications, so potentially a more realistic ED population. And so we were able to see some of this benefit in their specific AFib subpopulation, but potential confounding as far as that presentation goes. They also saw significant differences in metoprolol dosing, so potentially underdosing metoprolol in this study compared to our previous trial data. So in reality, where we don't see a difference between diltiazem and metoprolol, are we potentially underdosing metoprolol? There was more hypotension in this observational study with diltiazem, and also more bradycardia, but not statistically significantly different. So our takeaways here: faster onset, faster rate control with diltiazem. We also saw greater ventricular rate reductions. And then in the prospective trials, there was less hypotension with diltiazem. For metoprolol, this is kind of considered your agent of choice for HFrEF, which we'll talk more in the coming section. And then you're also going to be seeing comparable heart rate control, even if it is slightly delayed compared to diltiazem. And then kind of contrasting what we saw in the trial data, there was lower hypotension in observational studies. So kind of coming back to our patient, as far as which agent we might pick for them, blood pressure is pretty good, heart rate 149, we know they're in atrial fibrillation. So which agent would we lean more towards picking? It's kind of a trick question. So either of them would still potentially be acceptable options. And you would really just kind of base it off of kind of what your goals were for treating that patient, and then other kind of concomitant medications, drug-drug interactions with the diltiazem, with diltiazem, and just kind of considering in which patients you may want to achieve that heart rate goal faster, compared to others like that you would be more lenient and waiting for that heart rate control. So patient case number 2, patient HG is a 79-year-old male presenting with dizziness, shortness of breath, chest pain, and palpitations. He also had atrial fibrillation diagnosed in 2019, so kind of similar to our previous patient. However, this patient has HFrEF with a left ejection fraction of 30 to 35%. Blood pressure at 149/73. We also had a heart rate of 139 beats per minute, and based on our BNP, likely not in a current heart failure exacerbation. And per our EKG, we have atrial fibrillation on the monitor. So what is going to be our optimal agent of choice for this patient? So we're going to talk a little bit more about some literature that's come out that challenges our typical treatment for heart rate management in heart failure with reduced ejection fraction. So why is this kind of an important section to address? So really, these are two highly concomitant conditions, and they contribute to each other, as we've already seen in kind of our mechanism of atrial fibrillation slide. So rapid ventricular response can kind of help contribute to further hemodynamic instability, decompensation, and then also damage that can contribute to heart failure. And then heart failure can also kind of promote this inflammatory state that can encourage the atrial fibrillate substrate. We also see that there is 57% higher risk of mortality in these patients that have both of these conditions. So the guidelines recommend similarly beta blockers as your first agent and or digoxin, and then amiodarone as your second line option. They specifically recommend against the use of non-dihydropyridine calcium channel blockers during heart failure exacerbations for the AHA, ACC, HRS guidelines, and then specifically in patients with reduced ejection fraction for the European Society of Cardiology guidelines. And so they really attribute this to the negative inotropic effect of this class, which decreases myocardial contraction strength and can worsen HFrEF by exacerbating hypoperfusion. We do see some of this negative inotropy with beta blockers, but they are different in that beta blockers provide more of a neurohormonal benefit, which is why we typically lean more towards those compared to our non-dihydropyridine calcium channel blockers in chronic management as well. So this study was published in 2019 by Hershey and colleagues, kind of challenging the use of challenging this kind of idea on the use of diltiazem in patients with acute atrial fibrillation with HFrEF. So this was a single center retrospective cohort study. They included 48 adult patients that had AFib with RVR and documented ejection fraction less than 40%. Their primary outcome was rate control, so heart rate less than 100 beats per minute, or heart rate reduction greater than 20% within 30 minutes of administration of the IV dose. As far as comparing blood pressure between these two groups, similar, and then slightly higher heart rate in the diltiazem group at initiation of therapy. So dosing that they saw between these two groups, typically diltiazem had 15 milligrams per kilogram, which is kind of in line with our recommended dosing. Metoprolol was typically just 5 milligrams. And they did have the option to repeat the IV push bolus dose one time after 30 minutes. So here on the bottom left, you can see this baseline heart rate at admission, and then this immediate kind of change transition drop at 30 minutes. So based on kind of your median heart rate here, more benefits seen in this dark bar with metoprolol, but also some benefits seen with diltiazem, and this was consistently maintained afterwards. So similar heart rate control, a non-statistically significant difference. They also saw no difference in incidence of hypotension, bradycardia, or cardioversion, no difference in worsening heart failure symptoms between groups, and then also no difference in heart failure exacerbation-related admission within 7 days. And another study comparing the use of these agents in patients with heart failure, and this was not specifically limited to heart failure with reduced ejection fraction. They looked at adult patients presenting to any ED with AFib with RVR and documented heart failure. They did exclude any patients that were having a heart failure exacerbation. Their primary outcome was a heart rate control of less than 110 beats per minute within 30 minutes after IV push of either of these medications. As far as their blood pressure goes, similar between groups, and then a slightly higher mean heart rate with the diltiazem group. Typical dosing for the diltiazem group is kind of close to our 15 milligrams that we've seen before, but then also metoprolol was kind of close to that 5 milligrams. They did see that a higher percentage of metoprolol patients required a second dose versus diltiazem. So this chart down here on the left kind of breaks down the difference in patients achieving target heart rate between this purple group, which is your HFpEF group, and this blue group, which is your HFrEF group. So these darker bars are diltiazem, the lighter bars are metoprolol. So there was a greater percentage of patients achieving this target heart rate in the diltiazem group for HFpEF. And this kind of difference was seen at 30 minutes and then also at discharge. For our HFrEF group, there really was not a significant difference between heart rate control achievement between either of these groups. They did ultimately see in their total population of patients that more diltiazem patients achieved goal heart rate by discharge compared to metoprolol. Another thing to note here, however, is that there was greater reports of hypotension with HFpEF patients and diltiazem compared to metoprolol. The same effect was not really seen, although there was a little bit more, but not statistically significantly different in the metoprolol group compared to the diltiazem group for HFrEF. Okay, so coming back to our patient case, again, we've got our heart rate greater than 120. We've got a patient that is not currently in a HFrEF exacerbation, and they also have AFib. So what is going to be our agent of choice for this patient? I'm going to argue that it is still metoprolol, and why. Technically, either of these options would potentially be an acceptable choice. As we saw in our study data, there really wasn't a huge difference in safety outcomes between the use of diltiazem and metoprolol in these groups. However, these are observational studies, and this is not technically what the current guidelines support. So as far as which option I would still recommend using first, I would still probably go to metoprolol first, and we'll see more efficacy reported in coming slides with metoprolol. But I think these studies challenge this idea that you cannot use diltiazem in these patients. Based on this data, it is potentially an option that you could consider, particularly if you're not seeing adequate heart rate reduction with metoprolol alone. So I think just kind of highlighting this further, this idea that we can't use diltiazem in these patient populations really might apply more to this long-term harmful negative inotropy that contributes to remodeling, but it might not be quite as detrimental in the short-term acute management, quick control of their heart rate. And then kind of, it appears to be a little bit safer in HFrEF, but we did see higher rates of hypotension in HFpEF. So something that you would want to balance when you're using this medication in HFpEF. Okay, Patient case number 3, this is AF. She's a 55-year-old female presenting with fever, a temperature of 101.5, tachycardia, lightheadedness, dyspnea, and cough. She has a past medical history significant for atrial fibrillation, diagnosed in 2021. She also has type 2 diabetes, clearly uncontrolled, hypertension, hyperlipidemia, anxiety, and then also she had chest X-ray imaging consistent with lower left lobe consolidation, which was read as consistent with an infectious process. So kind of highlighting some of her more patient-specific factors that we're going to want to be considering as we move into our next section. Her blood pressure is down to 98/55. Her heart rate up at 144. We clearly have some kind of underlying issue as far as infectious process, so potentially a critically ill sepsis patient. She's hypokalemic, elevated lactate, blood glucose in the 700s, and then also urinalysis positive for ketones. Also, since presentation, she has gone from normal sinus rhythm, as we see here, into atrial fibrillation. So now we're going to talk a little bit more about acute management of atrial fibrillation with rapid ventricular response in our critically ill patients. The guidelines are a teeny bit vague about management of this in patients that are critically ill. So they really recommend that IV amiodarone can be useful for rate control in these patients. And then the European Society of Cardiology guidelines kind of echoes this. They don't definitively say exactly how they define critically ill. The studies that the European Society of Cardiology cited have patients that are just admitted to an intensive care unit. And then this study published in 2001 kind of delineates that a little bit further in the critically ill patients that have this Apache 3 score, and then also of older age, they're admitted to a medical or cardio intensive care unit. I do want to highlight here that critically ill does not necessarily always mean hemodynamically unstable most of the time. So all of our previous options should still be potentially on the table. So kind of looking a little bit further at what makes atrial fibrillation more complicated in critically ill patients. So you already have your kind of underlying mechanisms that contribute to this atrial fibrillate substrate and development into AFib at a chronic level. But in this state of critical illness, there are also other confounding variables and factors that can further increase somebody's risk of going into atrial fibrillation or make it more complicating to manage. In particular, vasopressor use has been linked to new onset AFib. You're also going to see potential electrolyte derangements in these critically ill patients that could contribute to AFib. Bacterial infection is another important factor because this has been shown to accelerate fibrosis, further contributing to structural remodeling and helping kind of trigger or kind of knock over the domino for somebody into atrial fibrillation. And we're going to focus in a lot of our studies coming up on sepsis and also vasopressor use in this setting. So kind of your approach to atrial fibrillation and critical illness is this new onset AFib. Are they hemodynamically unstable? And still by the guidelines, they recommend direct current cardioversion. Do we have a contributing medication present? Can we discontinue that if possible? Is there an underlying correctable cause that we need to address? And so here in this patient population, you may be looking more electrolyte replacement, ventilator desynchrony, myocardial ischemia, addressing volume status or underlying infection. And then if we've addressed all of these issues and we still have AFib persisting, causing adverse effects, then we're going to go to heart rate management. Which takes us into practice patterns and outcomes of treatments of atrial fibrillation during sepsis. So this was a propensity matched retrospective cohort study. They looked at 39,693 adult patients with initial sepsis hospitalization that also had atrial fibrillation. They were looking at patient and hospital factors associated with the choice of atrial fibrillation, and then hospital mortality associated with each of these agents. Non-dihydropyridine calcium channel blockers are the most commonly reported agents used, followed by beta blockers, digoxin, and amiodarone. So in comparing all of these classes versus beta blockers, they actually found that beta blocker use reduced mortality in their overall population as well as subgroup analyses. So also kind of highlighting down here that in these patients that were already on vasopressors and they also received an IV medication for rate control, beta blockers had superior mortality benefit compared to all of these other classes, including most notably amiodarone. And then also in patients with heart failure, we saw this same effect with greater efficacy of beta blockers for reducing mortality. And then in comparing effectiveness of heart rate control medications, specifically for sepsis-associated atrial fibrillation, in this multi-center retrospective cohort study published in 2021, they looked at 666 adult patients with AFib and sepsis. They were specifically looking at the rate of heart rate under 110 beats per minute after 1 hour after administration. Most of these patients actually received amiodarone, but we also had about 10% receiving a beta blocker, 33.8% receiving a non-dihydropyridine calcium channel blocker, and a smaller portion receiving digoxin. Here, relatively similar heart rate at time of AFib with RVR, with some slight changes. So ultimately here, in comparing all of these agents versus a beta blocker at their adjusted hazard ratio of achieving their target heart rate at 1 hour, we see superiority again of beta blockers with improved heart rate outcomes compared to all of these other agents. These were statistically significantly differences for beta blockers versus amiodarone and beta blockers versus digoxin. We also saw the same effect seen for amiodarone and DIG compared to beta blockers at 6 hours, but we start to see this difference kind of go away for calcium channel blockers at 6 hours. So kind of tying it back into our patient case, kind of highlighting some of these factors. So we clearly have an infectious process going on. We have a patient with atrial fibrillation. She's got some kind of underlying issues as far as controlling her diabetes, and then also some electrolyte abnormalities. So which of these potentially precipitated this episode of atrial fibrillation? Sorry, I only have tricky questions. All of the above could have contributed to development of this episode of atrial fibrillation. But this one should be pretty more straightforward. So what's going to be our agent of choice for heart rate control in this patient? Metoprolol. So we saw reduced mortality with metoprolol and also improved heart rate efficacy. So back to patient AH, we see that she's had a drop in her blood pressure. She also is still continuing to have this persistent heart rate of 136. We're also seeing some potential end organ damages or results. Her MAP is also dropping at this point in time pretty quickly, and she remains in atrial fibrillation. So we've provided adequate fluid resuscitation, and now we're considering starting a vasopressor, which takes us into this next kind of interesting recently published study comparing heart rate management after phenylephrine versus norepinephrine initiation in patients with septic shock and AFib. So this was a multi-center retrospective cohort study. They looked at 1,847 patients with sepsis and AFib at the time of initiation. And they were specifically looking at differences in heart rate between patients receiving these vasopressors at 1 and 6 hours post-initiation. Similar map between these groups, and then a slightly higher heart rate in the phenylephrine group. Oh. So what they found was that there was greater mean heart rate change reduction in the phenylephrine group compared to the norepinephrine group. And so this was statistically significantly different at 1 and 6 hours in patients with AFib and septic shock. And then in particular, we saw a greater difference in patients that had RVR at 1 and 6 hours. So here, this is a heart rate change typically of less than or reduced by 4 beats per minute with slightly higher efficacy with at 6 hours. So more pronounced heart rate reduction, and they attributed this to potentially avoiding that beta stimulation, which may kind of exacerbate some of this heart rate issue in some of these patients that are on norepinephrine. Here, though, I would argue, is this a clinically significant change in heart rate? So would this change as far as having a reduced heart rate of just 4 beats per minute be so clinically meaningful that you would pick phenylephrine over norepinephrine? So kind of here, kind of highlighting that issue as far as whether you would pick one over the other. We do have stronger guideline recommendations for norepinephrine and septic shock. However, if we're trying to avoid that beta stimulation, phenylephrine might be the better choice. But as far as our heart rate reduction, do we really get that much benefit from using phenylephrine? I think it's still debatable. So our takeaways, metoprolol appears to demonstrate superior efficacy and safety in patients with critical illness. Guideline recommendations for amiodarone may be a little bit more outdated and no longer supported and favor more of metoprolol. And then in our patients with AFib, RVR, phenylephrine may be more beneficial for heart rate reduction in addition to hemodynamic support compared to norepinephrine. And then our final section, looking at acute management of atrial fibrillation with rapid ventricular response, focusing in on that group that is hemodynamically unstable. And we're going to start by kind of highlighting how we define hemodynamic instability in this population. So there are subjective parameters that you can use, such as capillary refill time, blood pressure, urine output, or GCS. And then you're also going to be looking for specific presentations that may push you more in the direction of using a direct current cardioversion as opposed to pharmacological therapy. In general, if we can use pharmacological therapy, we try to take that approach. However, some of these patients that present with these more unstable positions may warrant direct cardioversion, such as presentations with shock, profound hypotension. If they have acute coronary syndrome, you may be more likely to lean more towards direct cardioversion. Patients with acute respiratory failure and distress, attributed mainly to pulmonary edema, or in then patients that have acute altered mental status. So as far as our guideline recommendations, could just kind of generally say cardioversion is recommended in these populations, and particularly in patients that don't respond to pharmacological therapies. And this is echoed in the European Society of Cardiology guidelines. So I'm not going to spend a ton of time focusing on this group, but there are some things that pharmacists can impact as far as cardioversion and kind of promoting patient efficacy or patient care in this setting. So pharmacists will be more involved in pre-medication with antiarrhythmics, anticoagulation, which we are going to spend more time on in the coming slides, and then also would have potential weigh-in for sedation and anesthesia. So transitioning into our final section, looking at considerations in anticoagulation, post-cardioversion, and critical illness. So as far as acute management, considerations for anticoagulation, you're going to base this mainly off of the duration of atrial fibrillation at presentation. So for our patients that have had atrial fibrillation for less than 48 hours, we typically consider these patients to be at lower risk for developing that left atrial thrombus that we're particularly concerned about and what would lead us to consider anticoagulation in these patients. So if there are patients that are less than 48 hours and they already have lower risk factors for or lower thromboembolic risk, these are the recommended agents, and you can potentially consider those. Post-cardioversion, this is typically not necessary. For patients that have higher thromboembolic risk, they do recommend initiating anticoagulation with these agents as soon as possible before direct cardioversion and continuing for long-term afterwards. In patients that present with a duration greater than 48 hours, and they're requiring immediate cardioversion, if they're not already on anticoagulation, initiate it immediately, and then also continue for 4 weeks after cardioversion unless otherwise contraindicated. And then all patients that are presenting with more elective atrial fibrillation, regardless of their CHA2DS2-VASc, you would want to make sure that they're anticoagulated 3 weeks before direct cardioversion and for at least 4 weeks after. So kind of a newer study published in 2021. So this is a systematic review and meta-analysis looking at thromboembolic events after direct cardioversion for acute atrial fibrillation. So they were looking at adult patients with acute atrial fibrillation, and they could have clear onset of symptoms less than 48 hours, or compare this to groups that had clear onset less than 7 days that were also receiving appropriate anticoagulation, or clear onset less than 7 days with no identified left atrial thrombus on a TEE. And these patients underwent pharmacological and electrical cardioversion. They were mainly looking at the incidence of thromboembolic events at 30 days. So overall, they had very low incidence of thromboembolic events. So just 61 events and 14,410 cardioversions. And in general, just as a note, the risk of bias in the study was overall pretty low. And so what they found was that the risk of thromboembolic thromboembolism at 30 days post-cardioversion was actually relatively similar between patients that received anticoagulation versus patients that didn't, kind of highlighting that this risk is overall generally pretty low. They did see an increased risk of thromboembolism in patients that already had baseline high embolic risk, though. So just kind of highlighting that potentially this risk is not equally high for all patients post-cardioversion. You're going to be a lot more concerned in patients that already have this high baseline risk. Okay, and then finally, looking a little bit more at anticoagulation among patients with AFib during sepsis. This study was published in 2016 in JAMA Cardiology. This was a retrospective cohort study. They looked at 27,000 propensity-matched adult patients with sepsis at the time of admission and AFib. They were comparing patient and hospital factors associated with the use of parenteral anticoagulations during sepsis. They're looking at in-hospital stroke incidence and also risk of bleeding. For baseline characteristics, most of these patients received, or about 35.3% received IV or subcutaneous anticoagulant doses greater than VTE prophylaxis, versus a comparator group of 64.7% that did not. And then most of these patients had anticoagulation for about 2 days. The most commonly used IV parenteral anticoagulant was Lovenox or enoxaparin, versus our PO option was mainly warfarin. And so in just comparing the relative risk of these groups for unadjusted rate of stroke, they saw there really was not a difference in this rate of stroke between patients that received anticoagulation versus those that did not. They did, however, see a higher risk of bleeding events in patients that did receive anticoagulation versus those that did not, kind of highlighting further that potentially the risk of anticoagulating these patients in this acute setting with sepsis is more risk as far as bleeding compared to your actual ischemic prevention benefits. So tying it all together, diltiazem is an agent that offers faster heart rate reduction, and it's potentially safer in our stable heart failure patients than widely appreciated. So would the recommendation still be to mainly use metoprolol in these patient populations? For now, yes. However, we do have data supporting potential efficacy in just the acute setting. For metoprolol, you do still see similar efficacy at 1 hour, so a slower heart rate reduction. But ultimately, we see better efficacy and mortality benefit in our critically ill patients, and then also in our heart failure patients. We did see slightly better heart rate reduction with phenylephrine versus norepinephrine in patients with AFib, with RVR and sepsis. Higher bleeding rates were associated with the initiation of anticoagulation for AFib in the ICU patients without added ischemic stroke benefit. We also saw time-dependent anticoagulation for cardioversion may not strictly be necessary in our patients that have low baseline cardioembolic risk. Or thromboembolic risk. So kind of tying in all of the takeaway points from this, challenging a little bit of how our guidelines approach some of the management of these of AFib with rapid ventricular response. And I'll open it up to questions now.
Right now, you still consider metoprolol patients heart failure guidelines should be updated.
So your question was specifically that I would still lean more towards using metoprolol in patients with heart failure compared to diltiazem, and do I think the guidelines should be updated to reflect potential higher safety with diltiazem? I honestly think that, this is observational data. It does seem to indicate that there is safety with it. I do think it would be worth potentially including in the next guideline update, but I do feel that there needs to be a bit stronger evidence to support that recommendation at this time.
I have a personal preference question for you. So you were talking about is the use of depressors and kind of which agent you would select for that. So if you had a patient that had AFib with RVR and was in septic shock, which agent would you use to treat each of those?
So that is a challenging question. And I think that was really what they were trying to address in the study comparing these two agents. So really, I think from a pathophysiologic standpoint, the premise makes sense. So in these patients with atrial fibrillation and rapid ventricular response, they already have high ventricular response, which is contributing to their reduced cardiac output and also reduced perfusion. So in considering norepinephrine, which also provides beta agonism, versus phenylephrine, which does not, theoretically, I think it does make sense to lean more towards using phenylephrine. In that observational study, however, I'm a little bit skeptical on whether that is quite as dramatic of a heart rate difference between these two groups. And we see stronger recommendations for the use of norepinephrine in this population for sepsis. So I'm still hedging, I guess, a little bit on definitively picking between one or the other because I'm not sure that that difference in heart rate is actually that profound. I do think that as far as kind of managing that acute heart rate state, if you had a patient that you had on norepinephrine, so kind of adding more beta agonism in that patient, you see heart rate, you start to see kind of not necessarily what you hope for clinical improvement, then that might be an opportunity to consider switching and see how it goes.